Hello, everyone. Welcome to today's live broadcast, The Expanding Role of Microbiology in Antimicrobial Stewardship. My name is Mohammed Qayyum. I'm the U.S. Marketing Manager for Identification Susceptibility Testing at BD, and I'll be your moderator for today's event. Today's educational webinar is brought to you by LabRoots and sponsored by BD. For more information about BD, please visit the website bd.com. Now let's get started. I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click on the Send button. If you have any trouble seeing or hearing the presentation, click on the Support tab found at the top right of your presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. I'd like to now introduce our presenters, Dr. Margie Morgan, Professor of Pathology and Laboratory Medicine and Scientific Director in Microbiology, Cedars-Sinai Medical Center, and also Dr. Toni Beavers, Microbiology Solutions Consultant with BD. For a complete biography on our presenters, please visit the Biography tab at the top of your page. Dr. Morgan and Dr. Beavers, you may now begin your presentation.
Thank you very much, Mohammed. It's really nice to be speaking to everyone today, and particularly speak about something that's just not directly related to COVID. But it's really not completely unrelated. Antimicrobial stewardship really does play a role even in our time of COVID, because I think all of you, at least we have, started seeing a bit of increase in antimicrobial resistance because so many antibiotics are being used this time. So I'm happy to be here today to share with you what our expanding role of microbiology should be in antimicrobial stewardship. These are my disclosures that you can view, and we'll get started with the topic. So why is antimicrobial stewardship important? Well, there's really many benefits that can be seen to the healthcare system of stewardship. It can actually lead to improved patient outcomes. It can reduce adverse events, including rates of Clostridium difficile infection. The rates of C. diff, of course, are very, very important to follow, and using proper stewardship can really help control your rates. It can also optimize resource utilization across the continuum of care, including the microbiology laboratory. Even though we might be spending a bit more money in some situations, in some circumstances, in the end, if you have good stewardship and good use of antimicrobials, will end up decreasing costs across the board. It also can help to prevent increasing rates of resistance to antibiotics. These are the urgent resistance threats to the public welfare that CD has listed on their website. And I think that probably all of us have dealt with some of these at a time or two. We've had issues here at Cedars with carbapenem-resistant Acinetobacter. Candida auris has not raised its ugly head yet here at Cedars, but it has certainly in the Los Angeles area. Clostridium difficile is an ongoing issue at Cedars every day. We're starting to see more CRE enterobacteriales, and thank God we have not yet seen drug-resistant Neisseria gonorrhea, but of course it's something that we're always aware of that could come our way. These are the serious and concerning resistance threats that CDC has listed on their website. You can view through this list and say, oh yes, we have also seen some of these. I have to admit one of the biggest issues we have currently been seeing at Cedars is multi-drug resistant Pseudomonas aeruginosa. So slowly but surely, a lot of these drug-resistant things are becoming a part of our daily operations. So the overuse and misuse of antibiotics are major reasons for the increasing rates of resistance that we are seeing in our bacteria and fungi. And so, of course, this has led to the federal mandate for hospitals to engage in antimicrobial stewardship. There's core elements of the hospital antibiotic stewardship programs that we're all supposed to be enacting in our medical centers. So I'm going to briefly discuss some of these. So the first one, of course, is you need to have a commitment of your hospital leadership. They need to provide funding for proper personnel, money for information technology resources. So much of stewardship is driven by data. You truly do need a huge computer operation on board to be able to assist you. And this all takes leadership commitment to supply the funds. How about accountability? Well, you certainly need to have a leader for stewardship. It's usually a physician or a pharmacist that is responsible for the program management and outcomes. At our medical center, we have infectious disease physicians that are in charge of our program, but it could vary. At other institutions, it might be a pharmacist that heads your stewardship. Whether you have a pharmacist in charge of stewardship or not, you do need to appoint a pharmacist or a group of pharmacists that are stewardship dedicated. And this can truly help move your program forward and can lead implementation efforts to improve antibiotic use. There needs to be action in your stewardship. You can't just say you have a program in place and do nothing, of course. So you need to implement interventions such as audits and feedback authorization to approve antibiotic use, or some other kind of active interaction to make sure that everyone is aware of what they should be doing and how they should be using antibiotics. We get back to data. Tracking and data is very important. We need to monitor antibiotic prescribing, the impact of interventions. Are changes really being made for the better? And other important outcomes, such as our rates of C. difficile infections and our ongoing resistance patterns. We also need to have reporting mechanisms. We need to regularly report information on antibiotic use and resistance to our prescribers so they know what antibiotics are best for certain circumstances. And we need to report to our pharmacists, our nurses, and our hospital leadership how all of our stewardship program is moving forward. And education. With all of our programs, education is so terribly important. We need to educate our prescribers, our pharmacists, nurses, and patients about adverse reactions from antibiotics, ongoing issues with antibiotic resistance, and optimal prescribing practices. So there's the outline of the stewardship program, but my goodness, microbiology can't do all of this. So what is microbiology's role in antimicrobial stewardship? The way I view this is our mandatory role is that we must prepare a yearly hospital-wide antibiogram and to list all of our most common organisms and their resistance pattern. And this is very important for our stewardship group to be able to prepare empiric therapy guidelines for our institution. Of course, it is also mandatory that the microbiology laboratory test and restrictively report antibiotics determined by stewardship as appropriate. And this is an ongoing yearly process, or maybe even more common than yearly, to make sure that we're testing and reporting the proper antibiotics. What can we do in addition? Well, we could provide rapid diagnostics to guide rapid escalation and de-escalation of therapy. We could also participate in quality management programs to improve the utilization of antibiotics. This might be starting a procalcitonin testing program in the laboratory. Start a reflex urine culture algorithm, so you only perform cultures when suggestive of infection. Tracking your C. diff rates and restricting antibiotic usage to improve the rates. Adding comments in reports to educate which pathogen might represent contamination. This has been a very useful recent addition that we've had to our program. Of course, we worked very closely with the stewardship committee to make sure that the reports that we are writing and putting into our reports met their criteria as well. And of course, we need to ensure timely reporting of our blood cultures. An important part of stewardship, of course, is the diagnosis of sepsis, and that then becomes a lot, or if not all, about the blood culture. So timely blood culture reports are very important. Empiric antimicrobial therapy given before you have the blood culture results is frequently inappropriate and can sometimes cause increased morbidity and mortality, prolonged hospitalization, and increased costs. So you want to really speed up your blood cultures as often, as much as you can, so that their patients are not on empiric therapy for a very long length of time. Decreasing the time between collection of blood cultures and reportable results have been shown by many reports to be associated with optimal therapy, improved patient outcomes, decreased hospital costs. So, what actions can we take in the microbiology to try to reach this goal of decreasing the time of collection of blood cultures and reportable results? Well, the first thing we can do is make our blood cultures as sensitive as we can. This can be very helpful, of course, in producing a good and timely result on our blood cultures. One of the key determinants of the sensitivity of blood cultures is the volume of blood that is sampled. I know this is always a great frustration for most laboratories because we're not necessarily in charge of the people that are collecting our blood cultures. But in the perfect world, we should collect at least 2 sets of blood cultures collected per septic episode in an adult. And of course, the higher the blood volume cultured, the higher the yield. The volume of the blood collected must be monitored and education efforts made to collect the recommended volume. We, of course, have systems. If you have BACTEC systems, you know that there's a way to monitor the volume of blood in the BACTEC. Some laboratories actually monitor them as they come into the laboratory. But there needs to be some way to monitor the different areas of the hospital and how they are doing their collection of blood and the volume that they're collecting. And it's really very important that this is part of a continued quality monitoring program in the microbiology laboratory. So we have it as an ongoing program and for reporting and education to the units that are not meeting standards. Every laboratory can set up a program that best suits their needs and with their computer capabilities that they might have. But you really do need to check the different areas of the hospital and check monthly and see how they're doing, and then of course go back and re-educate if they're not collecting the proper volumes. What about blood culture contamination? Well, each laboratory also needs to establish a quality management plan to achieve a blood culture contamination rate below the national benchmark of less than or equal to 3%. This has been the benchmark that we've been working with for years, but there's been so many publications recently promoting, trying to keep pushing and pushing to get this benchmark lower, because there's nothing that leads to more misuse or overuse of antimicrobials than having treatment for contaminated blood cultures. So there's several things that we could do. I'm only listing a few. You could probably give me even better ideas possibly, but you could switch from iodine to chlorhexidine scrubs. That's one thing, and that totally helped us lower our rates of contamination. There's also a lot of new devices that are on the market that can assist with providing you more clean draws. They might add some expense to your drawing of blood cultures, but there's nothing more expensive than having elongated hospital stays due to blood culture contamination that has led to overuse of antimicrobials and overtreatment and exposure to antibiotics when it's not necessary. Also, we've had ongoing programs in our hospital for improved care of catheter line hubs, such as using alcohol hub caps to prevent those catheter hubs from just dangling all over the patient's beds and such, and then not being cleaned adequately prior to blood draw. Rates also trend lower with a dedicated phlebotomy staff that draws your blood cultures. We're not so fortunate to have that at Cedars. We do have ED nursing personnel and also nurse collections on the floor doing some of our blood culture collection. but it has been shown in many papers that if you have a dedicated phlebotomy team, you're probably going to trend toward lower contamination rates. Also, an ongoing program must be in place to monitor contamination rate. This has even become a CAP inspection question, and so it's very important that we monitor our blood culture contamination and report back to units that are not that are failing our contamination threshold. So now, what comprises a contaminant? Well, it can be very difficult these days to accurately the differentiation of what organism is a contaminant. It's become more difficult as patients have become more complicated for both the clinician with treatment decisions and for the laboratory calculating contamination rates. I think we've all seen gram-positive bacteria causing true sepsis increase over the last decade or so. Of course, staph epidermidis and our other coag-negative staph, they're no longer only contaminants. So there needs to be a multidisciplinary approach with your stewardship group and others to determine criteria for what is actually considered a contaminant. And you need to, I think, add comments to your report to inform of possible contamination when you're reporting blood cultures. And this really drives that message home, is even though this grew something, please take a second look. There is a true possibility that this growth in the blood culture could be due to skin contamination. And as I said, contamination can lead to a major resource utilization issue and can lead to massive overuse of antibiotics. So it's really very important, of course, that we all look at our contamination rates closely and do our best to lower them. So how can we provide overall rapid results to help out our antimicrobial stewardship group and our patient care situation? Well, in a perfect world, we're going to do blood cultures collection in a timely and efficient way. And then they're going to be rapidly transported to the laboratory. Cultures will then be directly placed into automated blood culture instrumentation. We rapidly respond to a positive alert in the automated instrument, and we perform our gram stain quickly to give results to our clinicians and caregivers. These results are communicated and explained to a physician in a timely fashion. We will do our rapid molecular diagnostic tests rapidly, and then we will, following that, complete organism identification and susceptibility as rapidly as possible. This is the perfect world. We can aim to achieve this. Some of these things are actually a little bit out of our control, but in the perfect world, this is the best thing that we could possibly do to turn around rapid blood culture results. Also, at the same time, we're trying to do all of this performance. We can do rapid molecular diagnostics that can perhaps give our physicians and caregivers useful information. There's a variety of different products on the market now to be able to do molecular testing to provide this information. There's nucleic acid amplification-based methods for both ID and resistance markers. There's in situ hybridization-based methods for ID, such as the PNA fish and QuickFish. Although this is ending, at the end of the year, I believe these products may be going off the market. There's phenotypic susceptibilities using such systems as the Accelerate. There's mass spectral methods, of course, using MALDI-TOF that can provide very rapid identification. Magnetic resonance-based methods such as T2 biosystems that can supply ID and resistance marker testing from whole blood, and metagenomic shotgun sequencing methods for searching out bacteria, fungi, and viruses. So there's a variety of rapid molecular diagnostics available on the market, and so it's for us to choose which one might work best in supporting our stewardship efforts. Can rapid molecular diagnostic tests improve patient care? Well, I do think they can improve patient care, certainly, and they can provide some very valuable information. But as I'm going to say, it's not going to necessarily be the end-all and the only information that is going to be needed or helpful. So molecular diagnostic techniques that detect pathogens and antimicrobial resistance genes can be a tremendous benefit to timely diagnosis and management of sepsis. However, overall, they vary in ability to assist with proper therapy choices, depending upon the organism identification and if a resistance marker is actually detected. So for the gram-positives, identification of gram-positive bacteria can be quite helpful for therapy choices. And if it is particularly paired with resistance genes such as a MEK-A, that can provide very useful information for the caregivers to make alterations in antimicrobial therapy. But the gram-negatives gives you a little bit different picture sometimes with just rapid molecular tests. Now, if you're just doing identification alone on a gram-negative organism, depending upon your own hospital and your own patient population, having identification may not be adequate information to change therapy choices. Just knowing it's an E. coli, is that really all you need to know to make drastic changes in antimicrobial therapy? Most people would say perhaps not. Some emerging resistance mechanisms also are not detected by some of the rapid molecular diagnostic tests, such as the AMP-C gene in enteric gram-negative rods, or porin alterations and efflux pumps in Pseudomonas aeruginosa. So although these molecular diagnostic tests can help in some circumstances, help to improve antimicrobial usage, they're not the end-all and not the end result. You need more information. So how about these rapid molecular tests? It's complicated. A survey of non-ID physicians concerning the understanding of rapid molecular blood culture identification panel results showed that 60% of them said that they did adjust therapy based on rapid molecular results for the blood culture identification and molecular markers. However, only 53% correctly de-escalated therapy based on rapid molecular results for, say, methicillin-sensitive Staph aureus. So what's going on here? You gave them the results, but it seems like they didn't use them properly. So in a recent survey that was done, 2 in 3 of ID physicians that were surveyed believe that these newer diagnostic tests are becoming a little bit too complex for the non-ID physicians to fully understand. And the most unmet diagnostic need is really prompt identification of drug-resistant aerobic gram-negative bacilli. The other thing that I think is very important, and for what I said on the last slide, there's a lot of misunderstanding and maybe miscommunication of some of these results. So I bring a quote here. A rapid diagnostic test result that remains unchecked in the medical record is the tree that falls in the forest with no one around to hear it. So not only are they perhaps not understanding it, I think at times they're not even viewing it, because if we just put some of these rapid results into the computer, it's not necessarily saying that the physician's going to take a look at it. And so we've wasted some very expensive healthcare resources and potential leading to delayed optimization of care. They could have done a lot of good if the physician had looked at them, but sometimes it could be 24 hours or more before some of this information is actually viewed by the MD. So I think the point I'm driving home here is that it's really very worthwhile and wonderful that microbiology laboratories are performing some of these very rapid methods. But unless we combine that with real-time communication by phone, text, or web page with these results, you really don't have a good comprehensive stewardship program. I really think you need to have a program where you produce these results and then you communicate with the clinician via phone, text, or web page, and provide an explanation of the information to an antimicrobial pharmacist, to the physician, to someone to be able to take care of the patient correctly. And I think that's a very important part of performing these rapid tests. So keeping up with increasing resistance. Despite the ability of rapid methods to identify some of the key pathogens and resistance genes, as I said, none of these methods in isolation alone have shown diagnostic accuracy to the extent that they can be used as the sole microbiological information for therapy. You cannot get around that a well-performed antimicrobial susceptibility with multiple antimicrobial options is still the powerhouse, and this is what microbiology performs, and we provide this powerhouse. I think it's particularly important for the gram-negative rods, at least in my particular facility. And I think also, I just have to say that I think keeping up with gram-negative rod antimicrobial resistance has been particularly challenging in our laboratory. So much has been going on recently. We've had updates to all the breakpoints to help us support improved resistance detection for ESBLs and CPOs. But because of that, we've had to go back and revalidate all the breakpoints, and there's been a great deal of work. And you've really had to put a great deal of time in doing all of this properly. And then no sooner do you get that done than you're starting to see more of the resistant organisms, and you have to bring in new panels and new ways to test new antibiotics, and they require validation of new panels or new test strips or new discs. So there's just keeping up with antimicrobial resistance, particularly for the gram-negative rods, I think has been a major challenge. So the way we've approached it is we've used a combination of MALDI-TOF and the BD Phoenix for doing our susceptibility testing. We get rapid IDs, of course, using MALDI-TOF, and we switched over to the BD Phoenix Emerge panels, which offer a very broad selection of antibiotics and information. It provides confirmatory ESBL tests. You get also a CPO detect test, which I'll talk about in a moment, and you get a lot of therapeutic options for treating the carbapenemase producing organisms. Gives you a very broad list of antibiotics. I've put in the boxes the ones that are being more often used for CPOs, and it does give you a very nice panel with a very thorough information for the clinicians and the stewardship pharmacists to use for therapy. And this has proved very useful for us. Now, what is this BD Phoenix CPO detect test? Well, I think that at least we have, and I think I can say that most microbiology laboratories have struggled with the proper detection and characterization of some of the carbapenemase producing organisms. So this BD Phoenix CPO detect test is a qualitative confirmatory growth-based test that's in the gram-negative panel for detection and confirmation of class A, B, and D carbapenemases. So it uses meropenem and doripenem, tamoxicillin and cloxacillin alone and in different combinations with all sorts of various chelators and beta-lactamase inhibitors, and works together to provide us a test for the classification of the carbapenemase. And this can really help you detect those in the Enterobacteriales, the Pseudomonas aeruginosa, and the Acinetobacter baumannii. So this could have a very positive impact on your laboratory workflow and on therapeutic impact and infection control decisions because you're more accurately detecting carbapenemase producing organisms. So in summary, the antimicrobial stewardship should be a very coordinated program that promotes the appropriate use of antibiotics, and such programs should be administered by multidisciplinary teams composed of infectious disease physicians, clinical pharmacists, clinical microbiologists, and infection control practitioners. and should be actively supported by hospital administrators. I think you should learn and become partners with these people. Make them your best friends. They can be so helpful, and they have been so helpful to us in moving forward major projects within microbiology. We should be very proud because the microbiology laboratory plays a very important role in stewardship by providing identification and susceptibility data that drives therapeutic decisions for the optimum care of patients and the optimum use of antibiotics. So I will end those with my words, and now I will let Dr. Toni Beavers take over as the second part of our discussion about the laboratory role in antimicrobial stewardship. I give to you, Dr. Toni Beavers.
Thank you, Dr. Morgan. I am employed by BD Integrated Diagnostic Solutions as a Microbiology Solutions Consultant. As a disclosure, and the content related to clinical cases are a result of my published research and certainly my opinions. The purpose in our discussion to continue today is to discuss the clinical laboratory's role in providing applicable and actionable information that improves our processes in healthcare delivery, clinical responsiveness, and health outcomes while respecting financial constraints. Our objectives are to review the burden of sepsis and antimicrobial resistance as examples of collaborative focus, describe capabilities of clinical laboratory scientists and microbiologists in the continuum of healthcare, and understand limitations of diagnostic tests and how to convey to our stakeholders, as well as a couple of case studies. So first, we're going to begin by addressing the health and financial burdens associated with sepsis. And just to continue what Dr. Morgan mentioned, certainly globally there's an estimated 31.5 million cases of sepsis with 5.3 million deaths each year. Clinical studies certainly have demonstrated a twofold increase in mortality caused by sepsis when inappropriate antimicrobial therapy is given. We know that sepsis is a leading cause of death and critical illness globally, with hospital mortality rates of about 25 to 30%. And as Dr. Morgan mentioned, blood culture remains a critical tool in the management of sepsis within the laboratory system. So another, key statistic is sepsis is the #1 leading cause of death in hospitals. Again, we're talking about the United States here. There's approximately 270,000 people die from sepsis each year, representing a financial burden of over $62 billion. We also know that sepsis incidence is rising to a staggering 8% increase every year. As we identify causative organisms from septic patients, another key impact driver and opportunity for collaborative focus within antimicrobial stewardship programs is effectively detecting antimicrobial resistance. Unfortunately, as we head to 2050, the projections include approximately 10 million deaths at a cost of over $100 trillion per year. So basically, as laboratorians, we already have an impact on antimicrobial stewardship and clinical responsiveness. First, we can assess what we do, how we do it, and how we can help our stakeholders. For the remainder of the presentation, we'll consider each one of these following stakeholders and provide some potential ways to expand our role while we go about our daily activities within the laboratory. Again, as Dr. Morgan has already mentioned, one of the most familiar ways that impact AMS is by using antibiograms. Traditionally, these are only produced yearly or annually. We can certainly expand our repertoire of antibiograms by using a more focused approach. During my previous days in the laboratory, as MRSA became more prevalent, we were tasked with more frequent antibiograms focused on clinical conditions to guide outpatient therapy options. So for instance, this is an example of a very specific antibiogram reviewing outpatients that presented with skin and soft tissue infections, contributing specifically to staph. We were frequently asked to provide customized antibiograms for cystic fibrosis, hem-onc patients, and even healthcare-associated infections. This is another example we used for our antimicrobial stewardship program and empiric therapy considerations. Knowing organism incidence helps inform our clinical colleagues for optimal decision-making. The screenshot presents organism incidents isolated, again, from skin and soft tissue cultures from pediatric patients presenting to our ED. We use a similar approach to focus on our burn unit and ICUs, as organism incidence reports can also be a first step in determining which organisms may be relevant for patient population-specific antibiograms. That seemed to be really a conundrum for me in the past, is, okay, what organisms do I need to include on my antibiogram every year? And so an incidence report test is very, very helpful in that purpose. As laboratorians, we'll also receive special requests from our infection prevention and public health partners. This is an example of using an organism trending graph that helped our colleagues measure and track an outbreak of Shigella sonnei using real-time data. We also set an alert system to notify infection preventionists by smartphone whenever we had an increase in cases or whenever cases met a certain threshold. And the cool thing is the threshold can be very dynamic. So as seasons change and as other events occur within the community change, this can be a moving target. And of course, using software, we use the BD Epicenter for that, of course. You know, we can migrate with those necessary changes. So basically, if we look at global healthcare, new challenges are taking shape. We see evolving technologies, as Dr. Morgan mentioned, certainly with genetic and phenotypic new technologies. We also see rising bacterial resistance. And as we start to consider these new technologies, we should ask ourselves if these technologies can keep up with evolving resistance and are communication mechanisms enabled to, again, provide this accurate information timely to our healthcare partners as described earlier. For instance, how do we handle carbapenemase producing organisms, also known as CPOs, while managing our resources within the laboratory? Why is testing for CPOs important? Even though CPOs are typically low incidence pathogens, one single index case can certainly spread to multiple facilities within a relatively short time, and unfortunately go unnoticed. Early detection may help in reducing transmission. A real-time alert system within the laboratory can certainly provide a more rapid notification, especially if you practice cascade reporting or suppression of antibiotics, as typically an alert system at the hospital information level or at the laboratory information level may not capture resistance if the antibiotic is suppressed at the laboratory level. So let's take one step further. Why is routine testing for CPOs important? When comparing infections from carbapenem-resistant organisms to infections from non-resistant organisms, there is a threefold more chance that the infected patient is on an inappropriate empiric therapy, and those patients traditionally have a 12% higher mortality rate. They stay in the hospital longer, which certainly contributes to more healthcare dollars spent. These factors not only concern us as laboratorians, but also impact our clinicians, our pharmacists, infection preventionists, healthcare quality professionals, as well as the hospital financial controllers. And unfortunately, we're all affected by these statistics, and not just certainly our patients. So when we assess our scope of detecting emerging resistance and technological capabilities within the lab, we also consider that no system, product, instrument is perfect. As a normal progression of bringing on these new technologies and actually investigating these new technologies, during the validation and verification process, we have the opportunity to help our stakeholders understand these limitations and be able to discuss all of these, hopefully prior to bringing on these tests, so that we assess the relevancy within our patient population. And certainly in my previous lab days, we use the following communications strategically and modified as technologies evolved. Of course, it's affixing comments, it's serving as consultants, educating during infectious disease rounds. We had other ways too. We had actually a fun workshop situation in where pharmacists and clinical laboratory scientists were included in annual or twice a year workshops. So these regional and statewide collaborative workshops with pharmacy and laboratorians were so productive, and again, they were so much fun. The pharmacists reviewed and set up Kirby Bowers and MIC tests. and our clinical laboratory scientists learned from the pharmacists about pharmacokinetics and pharmacodynamics and the critical need of lower breakpoints in clinical care. So we basically just kind of understood the other end of antimicrobial stewardship, and again, we had a lot of fun in doing so. So now to just a couple of very brief case studies and how we use this rapid reporting system relative to antimicrobial stewardship. So one example from our previous lab experience using collaborative focus was a project we took on to reduce vancomycin use. This objective came down from the C-suite and required us to use real-time alerting to manage vancomycin interventions. Specifically, my CEO walked into my office and said, Toni, I want you to meet Dr. Maples. Dr. Maples, I want you to meet Toni. They're going to be best friends. We needed lower vancomycin use. So we kind of sat down and talked about how we were going to do this. For a very brief and quick look at this approach, we actually looked at 49 patients where we used the BD Epicenter and the Sentinel model to set up real-time alerts for inpatients with Staph aureus. We sent those alerts to the pharmacist, the clinical pharmacist's phone. As a result of the real-time alerting, we were able to obtain MRSA, MSSA results within the same shift. And in doing so, we were able to optimize vancomycin dosing. We were able to decrease vancomycin use and certainly decrease overall time to target therapy. And kind of as a sidebar, we were able to decrease time to infection prevention management for MRSA patients while still saving time due to the optimization of the laboratory workflow using these automatic results and alerts. Another example of the impact of real-time reporting occurred when we had a patient admitted to our burn unit with MDR Acinetobacter. As a result of the alert system within the BD Epicenter, we were able to initiate appropriate empiric therapy and infection prevention management sooner, and we initially installed it as soon as the index case presented to our hospital. So after that was initiated with the first case, and we used a collaborative focus, of course, a real-time alert was sent to pharmacy, infection prevention, and infectious disease with different reasons. So, for instance, one alert went to the infection preventionist, and they were able to do one-on-one nursing care, contact precautions, while simultaneously the same alert went to the clinician so that they could modify therapy. And then at that point, it became a reportable disease, so it came to the infection preventionist as well as myself so that we could report to the health department. And basically, this process eliminated multiple phone calls and saved our staff and certainly our patients critical time. So basically, how to measure success. You know, in this day and age, you know, we do wonderful things, but it seems like we're being tasked with measuring that success and reporting that success. So, you know, collaboratively, you know, we do things wonderful together, but still separately, it seems that we are tasked with different metrics. So, for instance, in the pharmacy, the traditional metric in the pharmacy may be antibiotic cost or days of use. So for vancomycin is cheap, so it could be how many vanc days per 1,000 patient days. Piperacillin tazobactam is more expensive, so it might be actually annual cost, quarterly cost. Also time to target therapy. You know, for instance, was a clinical pharmacist able to decrease time to target therapy in certain patient populations? And another kind of newer metric is called days of therapy avoided. So those are our pharmacy partners' traditional measures to success for antimicrobial stewardship. Now, in the laboratory, some of these may be for us is how many different tests are you doing? Did you start off with 3 different tests to measure oxacillin, cefoxid, and MEC-A testing, and now you're down to 1? You know, that's great. How much time does it take to set up a test? Average cost per test or average cost per pathogen may be another measure. For infection preventionists, traditional measurements are central line days per 1,000 patient days. Certainly healthcare-associated infections, isolation days per 1,000 patient days. And then again, our friends in our healthcare system Also for quality measures, look at length of stay, mortality rate, reimbursement, and certainly the hospital-acquired condition HAC scores by the CMS is another measure. So today we certainly hope we've given you some ideas on how to enhance your antimicrobial stewardship capabilities within the clinical laboratory while conserving resources and working with our partners. It's certainly within our reach by incorporating small but meaningful changes. Now, how do we measure success? Certainly collaboratively, of course. And now we're actually at our question and answer phase. And Mo, would you like to take it over?
Thank you, Toni, and thank you to Dr. Morgan also for your informative presentations. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box on the far left of your screen. We'll answer as many of your questions as we have time. So with that, let's get started. For Dr. Morgan, at the beginning of the presentation, you talked very briefly about the impact of COVID-19 specific to antimicrobial resistance. Can you talk a little bit more about your experience with COVID-19 and antimicrobial resistance and what lessons, if any, we can take from the pandemic about combating AMR?
Certainly. It's a very good question. I think two things were happening, at least our medical center, particularly early on during the COVID pandemic, and that was a lot of people were delaying hospitalization trips. They were perhaps not doing well at home, but they were reluctant to come into the hospital. So they were showing up at the hospital when they were really quite ill. And therefore, some of them were requiring antimicrobials and perhaps wouldn't have if they'd shown up earlier, but a lot of people were being put on antimicrobial therapy. At the same time, we were getting a very high census of COVID patients that had, of course, a lot of respiratory and lung issues, and they were all being treated for the possibility of secondary bacterial infections. So it just seemed like for a very long period of time, we had a lot of people on very high dose of antibiotics, and I do not think we're unique. I think this has been the situation. So the combination of high use of antibiotics over a long period of time, and that can certainly lead to acquired resistance. Also, transmission of organisms. I think that during some of this time, there were so many COVID fears and COVID precautions and COVID protocols being put in place that we did a bit, and I've heard from other institutions as well, that there was possibly more transmission of organisms than you would have liked to have seen. So you put all that together, and there just seems to be a little bit more resistance moving around our hospitals these days.
Thank you. Next question, and this is for both of our speakers. With your lab experience and your time in the lab, what recommendations would you give to an organization that's early on in their partnership with antimicrobial stewardship? And as a second part to that question, how can the microbiology lab become more involved or a better partner to antimicrobial stewardship programs? So I'll ask Dr. Toni Beavers first, and then Dr. Morgan, if you could chime in as well.
Thanks, Mohammed. So it was actually getting to talk to one another. And so I literally sat down with our clinical pharmacist and our chief of infectious disease. We sat over coffee and we figured out, what is the number one objective that we need to do. We had to make it simple. So we didn't have a lot of funding. Actually, we had no funding. We had very little personnel resources. And I didn't want to certainly increase the time in our laboratory. So the only singular function that we were able to initiate was vancomycin, and actually it was the most powerful. It was an incredible journey, and we learned a lot. So basically, just sitting down, talking with our partners, and asking, what is the easiest, simplest thing that we can do to make the biggest impact.
If you're finished, Dr. Beavers, I'll say that I think the one thing that has been the greatest advantage for me over the last 10 years or so is really becoming good friends with my pharmacists, my ID physician that are on stewardship as well as in infection control, and really making a good partnership and being able to use them for assistance. We've become very close, and they need me as much as I need them, and we've worked together in trying to make policies and procedures. And I do not think that microbiology laboratories can be in their own silo and not be directly involved with their stewardship committee. It's really, you can learn a great deal from them, and they will learn that they can learn a great deal from the microbiology laboratories as well. And it's truly a group effort.
Great, thank you. We have time for a few more questions. I just want to remind our audience that those questions that we're unable to answer today and those that come in during the on-demand period, we will answer, or the speakers will answer via email address that you provide at the time of registration. So now we'll move into some additional questions here. For Dr. Beavers, you spoke about the alerting system in BD Epicenter that enabled early notification of clinicians for critical organisms. Are there other capabilities in your experience with the BD Phoenix system to help support AMS initiatives?
Wow, great question. So as we progress through our antimicrobial stewardship goals, we did find some additional advantages, and we practice cascade reporting. So for instance, if cephazolin was susceptible, we didn't cascade to the second, third, and fourth generation cephalosporins. And so we did that. We also suppressed linezolid and daptomycin and whatnot. But if we suppress that, the problem is it didn't go to the LIS, and so we had additional software that would not get through. So we did use the Epicenter and Sentinel to alert us when we had situations of non-susceptible linezolid or cases of previously clustered organisms, such as we had Serratia marcescens in our nursery at one point. So we had an alert in the background mining that in case that came up again. So anything that we needed to be alerted about, because if infection prevention needed one-on-one nursing care or contact precautions or any reportable disease, those are the things that went to the infection preventionist, and anything I needed for CLSI follow-up, or if I needed to freeze the organism, or if I needed to do some fingerprinting or whatnot, that was all going behind the scenes in surveillance without the technologist even knowing about that. So they didn't have to worry about not catching a certain scenario. There was another case of our cystic fibrosis population, their first isolate of Pseudomonas aeruginosa and all isolates of Burkholderia cepacia. All of those were alerted to our chief of pulmonology and our nurse practitioner for pulmonology.
Okay, great. We have I think, more specific question here that I'll open it up to both of our speakers. Can procalcitonin used in conjunction with molecular resistant markers be used to reduce MDR, Pseudomonas, or Acinetobacter infection? And do you think that's a practical idea or suggestion for smaller diagnostic facilities?
Dr. Beavers, you want to take that one? All I can say is I think that in our medical center we have a 950-bed facility at Cedars. We've had variable use. Well, we've had variable success with our procalcitonin program, and I think that perhaps in a better setting, a better use of the program, you could use it in that case. I would say in our institution, we would not have success doing that, but Dr. Beavers might have a very different look on that. So take it away, Dr. Beavers.
Okay, and back to, I would recommend looking at your patient population and almost even doing like a little pilot study to look at, how does this behave in your patient population? It may be effective and it may not. Again, depends on where you are in the country, what type of patients that you see. So, procalcitonin is not a magic bullet, but it certainly may be effective within your patient population. But, you know, there's only one way to kind of understand that, and that's kind of do a little bit of pilot study or you know, do a little bit of research on that before you do a widespread initiation throughout the entire facility.
Yeah, don't you think, Dr. Beavers, that it's proven, procalcitonin is proven to be a little bit trickier to use than people initially thought?
Yes.
Yeah,
yes.
That's the point I'm trying to make. We thought we had it in the bag, and then when we started using our program that we thought would be wonderful, it didn't end up providing us the results that we thought it might.
Okay, so thank you again, Dr. Morgan and Dr. Beavers. Before I say some closing words, do you have any final comments or feedback for our audience?
I have to say thank you for inviting me to speak today, and I just can't say more about finding partnerships and moving forward in stewardship. It's a lonely world out there in microbiology laboratories sometimes, and if we have the support of our pharmacists, stewardship pharmacists in particular, infection control and infectious disease people involved in stewardship, it can just be a much easier trip through trying to obtain our goals of better use of antibiotics.
Yeah, I absolutely agree with that 100%. And I'd also like to add that whenever it was time to purchase new technologies and new equipment, I always went to my clinical pharmacists and my infection prevention partners, as well as my infectious disease partners, and said, I need this new equipment. I need this new technology. You know, we've talked about it. You know, here's how much it costs. Can you help me do a cost justification, the total cost of ownership, so that we can bring this on board for our patients? So they can be your partner in whenever you're seeking funds to bring on. You don't do this in a silo. You know, they need you. They need us in laboratory. And we're here to help, but we have to have that support for, you know, purchasing capital equipment and these newer technologies.
Okay, great. So before we go, I'd like to thank the audience for joining us today and their interesting questions. Any questions that we did not cover and those submitted during the on-demand period will be addressed by the speakers via the contact information you provided during time of registration. We'd like to once again thank Dr. Morgan and Dr. Beavers for their time today and their important work. We'd also like to thank LabRoots and BD for underwriting today's educational webcast. You can view this webinar on demand. LabRoots will alert you via email when it's available for replay. So with that, hope everyone has a great rest of their Friday and great weekend. Until next time, goodbye. Thanks.